Conclusions. Promenoris almost never causes an audiological or occupational deficit, yet the mental and emotional strain can take a tremendous negative toll on patients. Otoplasty is a rewarding procedure with low morbidity and high rates of surgical success and patient satisfaction. Patient and family satisfaction is also dependent on adequate preoperative counseling and the surgeon's understanding of patient expectations and psychosocial concerns. Accurate preoperative diagnosis of the specific components of the deformity, proper planning, and excellent technical execution of the procedure are paramount to obtaining a good, long-lasting, aesthetic result. One of the most important steps in otoplasty is the correct analysis of each ear deformity. The ideal technique should not leave residual foreign bodies in the ear, especially permanent sutures, have minimal incisions and have a dissection limited to the defect. Surgery should precisely correct the cause of the deformity and avoid sharp ridges on the antihelix or conchus in order to produce a natural result. Do not believe in a one-size-fits-all approach to cosmetic surgery. Never give up on a dream just because of the time it will take to accomplish it. The time will pass anyway. Pearls. Otoplasty is a game of millimeters, and that I cannot guarantee that each ear will be exactly the same, and that a several millimeter asymmetry is acceptable. Ears are considered prominent when they protrude more than 20 mm and at an angle greater than 35 degrees from the occipital scalp, though there may be personal and ethnic influences on individual preferences. The fact that hundreds of techniques for the correction of prominent ears have been described over the past 50 years attests to no one technique being effective in all cases and that no single technique has emerged as the gold standard, and all have potential advantages and drawbacks. The most common mistake in otoplasty is overcorrection. Aggressive skin removal is not necessary as excess skin removal does not keep the ear posteriorly positioned and can produce tension and scarring. Fast faxes. Over 200 techniques have been described for correcting a prominent ear. Undoubtedly, the most widely used method for otoplasty is that of mustard. Selection of the appropriate technique for correction of prominence depends on many factors. These include the specific wishes of the patient, previous surgical intervention, the specific shape of the pinna, the patient's age, the elasticity of the patient's cartilage, i.e., soft, moderate, or firm, and the surgeon's personal experience and expertise. The benefit of the collegial transfer of knowledge and sharing of new ideas and modifications of old ones is that the student may avoid mistakes committed by the teacher. 1. Philosophy of undercorrection trumps the effort to achieve perfection. 2. Otoplasty is more than creating an antihelical fold. 3. Prevent postoperative deformities rather than fixing them by analysis, and then surgical planning rather than recipe following. But have an exit plan for each deformity. 4. Remember the potential of early neonatal intervention by molding and share with neonatal colleagues. 5. Normal has a wide variance. A firm understanding of normal is an excellent relative guide, but your aesthetic sense as a surgeon, not as a technician paying attention solely to angles and measurements, is the best guide. 6. Artistry of otoplasty is in the degree of each progressive correction to achieve a natural relative relationship of each part leading to a natural whole. 7. Know the normal, assess the defect, create a thorough surgical plan, follow through. Cases without cartilage excess can be treated with a mustard procedure only as previously outlined. By the same token, some patients present with a normal AHF but with posterior conchal wall and bowl excess and can be treated with cartilage excision only. To be proficient in otoplasty, the surgeon must master both techniques. For novice surgeons, the Davis procedure and the mustard procedure are difficult to conceptualize without actually witnessing the procedure several times. An effort should be made to educate pediatricians, obstetricians, midwives, and nurses to identify auricular deformities early on before the window for non-surgical intervention closes. This may reduce the need for future surgical correction in children. Take-home messages. The golden rule for treating ear prominence is to fit the ear to the face for a more natural appearance, not to make people look better. Generally, techniques that employ cartilage scoring or abrasion should be used cautiously and only superficial, as they all run the risk of cartilage weakening and visible irregularities. An aesthetic antihelix can only be achieved by conservative procedures. Mustard, 1963, Skoog, 1974, Olsen and Vidung, 1980, involving no incisions or excisions of the antihelix cartilage. Another important caveat is to preserve the perichondrium on both the anterior and posterior surfaces, as it lessens the risk of sutures pulling through the cartilage and a subsequent recurrence of the deformity. Hasty treatment approaches that concentrate only on antihelical effacement sometimes cause unintended results like overcorrection. Atwood and Evans stated that there is an inherent difficulty in folding cartilage in a curve without prior weakening of the cartilage. My own preferences. Skin incisions. The incision is best placed in the retroauricular sulcus, not up on the back of the ear. In case I will manage the lobule, I use a dumbbell-shaped incision. Skin excision. For me, skin excision is unnecessary, does not contribute to the correction, and may lead to hypertrophic or undesirable scars. Techniques. The simplest techniques are best. Techniques that involve abrasion or full-thickness incisions and/or tubing to create the antihelical fold are unnecessary and should be avoided. For conchal hypertrophy, I prefer Davis procedure, i.e., conchal bowl resection leaving around 10 mm as the conchal wall, and in some cases, I may add some conchomastoid sutures to prevent recurrence, while resting the newly created conchal floor on the smooth mastoid bone to minimize irregularities. Sutures. Monofilament undyed permanent sutures are preferred for creation of the helix, because of occasional granulomas associated with braided sutures, and the undyed suture doesn't show under the skin. Correction. Overcorrection of the ears is the most common problem and should not be permitted. Contours should be soft, round, and natural rather than sharp and surgical in appearance.